Hi everyone. My name is Muhammad Sajid. I am from Pakistan. I am working as an emergency medical technician in Punjab Emergency Services Department Rescue 1122. I am very thankful to Mr. Marko Kokovic and his team who gave me chance to present presentation in this beautiful 3rd IMRUA Congress. Today's my topic is airway obstruction. Let's go to our topic. What is airway obstruction? Times an airway obstruction is a blockage in any part of the airway. The airway is a complex system of tubes that transmits inhaled air from your nose and mouth into your lungs. An obstruction may partially or totally prevent air from getting into your lungs. Some airway obstructions are minor, while others are life-threatening emergencies that require immediate medical attention. Let's talk about my specific topic: pediatric airway obstruction. Major choking episodes in children and infants usually occur during feeding or playing and often witnessed by a carrier. However, remember to ask about any recent history of playing with or eating small objects and consider choking with or eating small objects and consider choking if any child with sudden onset of breathing problems. The severity of the obstruction can be determined by the effectiveness of the patient's ability to cough. An effective cough is better than external maneuvers. So an actively coughing child should be encouraged to continue to do so. Let's know about main causes of pediatric airway obstruction. There was two common causes of airway obstruction. First one is anatomical causes and second one is mechanical causes. Now define anatomical cause of airway obstruction. Times tongue is mostly common cause in unresponsive patient. Medium black circle epiglottis or inflammation of airway. Now talk about mechanical cause of airway obstruction. Mechanical, for example, medium black circle coins is most common in children. Times food is common cause of airway obstruction. Toy is also cause in children or any foreign object. Types of airway obstruction. The types of airway obstructions are classified based on where the obstruction occurs and how much it blocks. Next, I will tell you about types of airway obstructions. First one is upper airway obstruction. Second is lower airway obstruction. Third is partial or mild airway obstruction. Fourth is acute airway obstruction. And fifth is chronic airway obstruction. Upper airway obstruction. Upper airway obstructions occur in the area from your nose and lips to your larynx, voice box. Lower airway obstruction. Times lower airway obstructions occur between your larynx and the narrow passageways of your lungs. Partial airway obstruction. Times partial airway obstructions allow some air to pass. You can still breathe with a partial airway obstruction, but it's difficult. Times acute airway obstructions are blockages that occur quickly. Choking on a foreign object is an example of an acute airway obstruction. Chronic airway obstruction. Medium black circle chronic airway obstructions occur two ways: by blockages that take a long time to develop or by blockages that last for a long time. Let me give some more details of the mild and complete obstruction of the airway that we are most likely to encounter in this type of emergency in the field. Mild or partial airflow obstruction. Medium black circle partial airway obstruction, the patient will be able to breathe and cough. Although there may be a crowing noise, stridor, as air passes through a narrow space. Usually, the patient can clear a small foreign body by coughing, and although breathing may be noisy, air can still enter and leave the lungs. Sign and symptoms of a mild airway obstruction. Crying verbal response to question. Long cough. Able to take breath before coughing. Fully alert. Contrast this with signs of a severe airway obstruction and an ineffective cough. Tell you about some more signs and symptoms of a mild airway obstruction. Obstruction. Unable to verbalize, quite silent cough. Unable to breathe. Medium black circle cyanosis. Decreasing level of consciousness. Now I tell you about complete or severe airway obstruction. Incomplete airway obstruction. Patient will be unable to speak, breathe, or cough. Patient may clutch the neck with thumb and fingers. Death will follow rapidly if prompt action is not taken. Now I tell you about management for airway obstruction. Times management of the choking pediatric patient depends on their ability to cough effectively, whether they are conscious or unconscious. Conscious and choking infants. Start with back blows. If your patient is infant, sit on a chair or kneel on the floor and place the infant across your lap in a prone, face down position. Support their head with the thumb and the fingers of one hand at the angle of their jaw. Conscious and choking infants continue. Times administer up to 5 sharp blows between the scapulae with the heel of your other hand. In these fail, turn the infant onto their back with their head downward. Locate the landmark for chest compressions and administer up to 5 chest compressions, making them sharper and slower than those administered during cardiac arrest. I show you in this picture about back blows position for infants. I show you in this picture about chest compressions position for infants. Until object comes out or patient unresponsive, this procedure continue. Children over 1 year of age. If the patient is child, support them in a head-down position and administer up to 5 interscapular blows. If this does not clear the obstruction, abdominal thrusts by standing behind the child and leaning them forward. Place a clenched fist midway between the xiphisternum and belly button. Grasp the fist with your other hand and pull inward and upward up to 5 times. Now I am tell you about if patient is unconscious and choking. If a child or infant becomes or is unconscious, place them on their back with appropriate padding to maintain an open airway. Check the mouth for a visible obstruction and make a signal attempt to remove it if a foreign body is visible. Don't forget to check the airway for a dislodged foreign body after reopening the airway prior to ventilating. Key points. Times after giving the details, I will now tell you the important points of today's topic, so that if any child is choking in your home or anywhere, you can use this technique to remove it. Let's discuss in detail what should be done in case of pediatric airway obstruction. First of all, for confirming airway obstruction, take choking kid history from his/her mother or any family member. And signs and symptoms are the main means of confirming airway obstruction. With the heel of your hand, give a firm back blow between the shoulder blades. Give up to 5 back blows. Place the infant's head lower than the trunk. Give 5 gentle but firm chest compressions with your fingers. Place 2 fingers just below the nipple line. Patient lowered safely to the ground. Request for ALS. Inspect airway, remove object if visualized. Times attempt up to 0.5 rescue breaths. Commence CPR with compressions. Inspect airway before ventilation. Infant CPR hand placement. Position your 2 fingers in the center of the chest around the nipple line. Compress the chest down to a compression depth of 1.5 inches or at least one-third of the chest. Compression rate is 100 to 120 compressions per minute. If object has become visible after one cycle approximately, perform finger sweep. Remove the object with your finger only if you can see it. Check breathing. After object comes out with finger sweep and breathing is present, then ensure adequate ventilation and oxygenation. Check circulation. If pulse is present, it means your CPR compression were performed effectively. Now I share an experience with you. Mr. Nadeem EMT immediately responded to the control room call. A 1-year and 6-month-old child with food stuck in his respiratory tract. With Heimlich maneuver procedure removed the child's food piece from airway and save valuable life. I am thankful to all of you for giving your valuable time and listening to my presentation.